How safe is your MS medication? That is exactly the topic of this discussion. I'm going to be diving into safety and tolerability of MS disease-modifying therapies. Now don't turn away, because all of that starts right now. Hey! Howdy! Thanks for learning about MS with me, Aaron Boster. This video is part of a series I've been doing on disease-modifying therapies for multiple sclerosis. The previous videos we covered topics such as route and frequency of administration, mechanism of action, and efficacy. If you've missed those videos, don't worry about it. You can click this link right here and check them out. Today's video is focused on tolerability, safety, and risk of these medicines. With that stated, let's jump in. Now, just before we jump in, I want to make a couple quick disclaimers. For starters, this is going to be a super long video because there's a lot of drug side effects to go over. And so I'm going to create chapters. So if you don't feel like listening to the details of every drug, you can just skip ahead to the drug of your interest. Second of all, this is not going to be 100% comprehensive. And so I'm going to go over the major side effects and the most important side effects of each of the drugs, but I'm not guaranteeing you that I'm going to hit every single one of them. And third, as always, this is just for educational purposes. This is to teach you information so that you can make informed discussions with your clinician, and it doesn't replace talking to your doctor about this stuff. Just wanted to throw that out there. So let's jump in. There are several different ways that one could frame a discussion about side effects, tolerability, and risk. And in this video, I'd like to try to do it in two separate ways. First, I want to take a bird's eye view and I want to talk about tolerability and safety in groups. Then I'll shift our discussion to talk about specifics for each individual MS medicine. So when thinking more holistically, one might consider side effects related to the route of administration. What do I mean by that? Well, if a medicine is taken by mouth, a pill, boom, then you may expect to have some GI issues because the drug has to be processed through the gut. And some of the MS pills certainly can have GI upset as part of their side effect profile. For example, Tecfidera, Fumarate, and Aubagio. Now, not all the pills do, so I don't really see much GI upset with the S1P receptors like Gilenya and the Me Too drugs or Mavenclad. When we think about self-injections, whether it's subcutaneously or intramuscularly, one might expect to see injection reactions, either a local site reaction of the skin or a systemic reaction caused by the injection. And that's certainly what we would expect to see with the interferon beta products. This would include Plegridy and Avonex, Rebif, Extavia, Betaseron, as well as Copaxone, glutamate acetate. To a lesser extent, I can see a skin reaction with Kesimpta. When you think about the route of administration of an IV, an infusion, you can have an infusion reaction where your immune system is not responding well to what that infused drug is doing to your cells. And we can see infusion reactions with many of the infused MS medicines, such as Lemtrada and ocrelizumab, and to a much lesser extent with Tysabri. So that's one way that we could consider these side effect profiles. Another way would be to consider it based on the mechanism of action. What I mean by this is that certain mechanisms are going to tend to have certain side effect profiles. A very easy example is a discussion about immunosuppression. So earlier in this series, I did an entire video talking about the mechanisms of action of the immunosuppressant MS medicines. So I'll throw a link right there in case you want to check that out. When you're dealing with an immunosuppressant, the constellation of side effects tend to be as follows. There's risks of opportunistic infections because you're suppressing the immune response, so that infection might have a leg up. You can see an increased risk of cancer in some cases because of suppressing the immune response, which keeps cell cycles in check. You can see concerns related to birthing a baby and teratogenicity, birth defects. And lastly, and this is rather relevant during the COVID pandemic, the response to vaccines may be suppressed because you have suppressed the immune system, and you need an intact immune system to mount a vaccine response. So keeping those things in mind, some of the MS medicines have some of those side effects. For example, alemtuzumab, Lemtrada, can cause risks of cancer, risks related to birth defects, risks related to infection. The B-cell depleters, which suppress the immune system by knocking down B cells, you can see increased risk of infection. When you think about Mavenclad, which is a immunosuppressant medicine in some respects, you also can see a slight increased risk of infection. There's concerns of teratogenicity as well, and you can see an increased risk of cancer. Then you look at what I refer to as pseudo immunosuppressants. Tysabri, I believe, is a compartmental immunosuppressant, and there's a risk of an opportunistic infection, PML. When you think about the S1P receptors, these are functional immunosuppressants because they take your cells out of circulation. And again, you can see an increased risk of cancers, and you can see an increased risk of infection. My point here is you could think about the different side effect profiles based on their mechanisms of action. Thirdly, again, keeping our thoughts sort of global, you could consider the medicine side effect profile based on how they are metabolized in the body. Now, as it turns out, most of the MS medicines are metabolized in the liver. And so it's not surprising that the vast majority of the MS medicines require liver monitoring. In fact, the only ones that really don't would be the B-cell depleters and Copaxone. All of the rest, we're going to be checking the liver enzymes. So I wanted to spend a few minutes just talking at a kind of a global level about how we might consider and even expect or predict side effects. With that stated, now let's turn our attention to a discussion of individual side effects, risks, and safety for the MS disease-modifying therapies. Hey, do me a favor. If you like this video, would you please give it a thumbs up? And if you haven't yet subscribed to the channel, please consider doing so. Those two actions are totally free, and they teach the YouTube algorithm that you dig this content and help push it out so more people impacted by MS can benefit. Thank you. We'll start by talking about glatiramer acetate, or Copaxone. This is a self-injection, and you certainly can have injection reactions. You can have welts that can hurt or itch. Rarely you can see a systemic injection reaction where the person feels like they're having a panic attack or a near heart attack. It's actually not physically dangerous. It's just really scary if you don't know to expect it. Fortunately, it's very, very uncommon. Also, when I think about Copaxone, we have to talk about what I refer to as injection fatigue, because injecting yourself 3 times a week can be palatable, but doing it for years and years or decades, it can become really, really challenging for the individual. You can develop lipoatrophy from Copaxone, where you get a divot in your skin from injecting over time. Now, one thing to point out is that Copaxone has arguably one of the very best safety and tolerability profiles. It doesn't cross a membrane and it doesn't stimulate a receptor. And as a result, Copaxone doesn't really interact with other medicines, and Copaxone doesn't really have a major impact in systemic diseases. So back in the ancient days of yesteryear, before the new modern medicines, this was the absolute go-to if someone had MS and a complication like MS in pregnancy, MS in HIV, MS in cancer. And Copaxone still may serve that purpose in some clinics because of the high safety profile. Next, let's turn our attention to the interferon beta products, Plegridy and Avonex, Rebif, Xtavia, Betaseron. These are self-injections, and so just like with Copaxone, you can have an injection reaction where you gave yourself the shot. And just like with Copaxone, we can have issues with injection fatigue over time. These medicines are metabolized by your liver, and so you need to check liver enzymes. Rarely they can interfere with your thyroid, and so you need to monitor your thyroid. And super rarely they can drop your white blood cell count, and so we need to check a CBC. So we're definitely going to be following some labs when taking these medicines to keep people safe. One of the biggest concerns with these medicines is flu-like side effects. So the class of medicine is called interferon. And when you get a flu bug, like when you get a virus, your body makes interferon. Your immune system makes interferon to interfere with the virus. Now, if you bottle interferon and inject it into you, it'll make you feel like you have the flu. And that's a major issue which sometimes can really challenge the adherence of having to take interferons over time. I do want to say that interferons are quite safe, all things considered. And just like with glatiramer acetate, we can use them in pregnancy, and they're amongst the safest of the MS medicines available. Next, we'll talk about the pill Aubagio. The route of administration is oral, and as you might expect, you can see some GI upset or diarrhea. This drug is metabolized by your liver, and so you have to check liver enzymes. And in fact, for the first 6 months, you need to check them every single month. And then after that, you can do it once every 3 to 6 months. The reason is, if your liver enzymes are going to spike while on Aubagio, they tend to do it in the first 6 months. And so we want to be really on point so we can catch it if it happens. Aubagio rarely can elevate your blood pressure. Aubagio rarely can cause what's called a neuropathy, where you can have numbness and tingling in the fingertips and toes. And in about 14% of people treated with Aubagio, they can have thinning hair. Now, this is not thinning hair, this is male pattern baldness. Thinning hair is what happens, it's actually kind of interesting biologically. When a woman becomes pregnant, she may notice more hair comes out in the comb. That's because all the hairs get in the same cell cycle and they grow at the same rate, and then they become disparate again. And that's actually what happens in about 14% of people that take Aubagio. It kicks in at month 2 and it ends at month 4. And so we don't have people stop the drug because it won't matter. It's gonna end 2 months on its own. Aubagio is not a drug that we want you to become pregnant on, as there's a risk of birth defects. And it also has a very long half-life. So if you stop Aubagio, it's going to take 18 to 24 months for it to naturally leave your body. Now, under many circumstances, that's okay. But if we need to get it out quickly, for example, if you unexpectedly became pregnant, there is a way to rapidly pull it off your body. There's a rapid elimination procedure where you have to basically drink some gross stuff 2 or 3 times a day for 11 days in a row, and it pulls off the Aubagio. Now, it is worth mentioning that Aubagio is an immunomodulatory drug. It's not immunosuppressant in nature, and as a result, we don't see a suppression of the immune response with an increased risk of opportunistic infections. And so that's a perk. Next, let's turn our attention to another immunomodulatory oral medication. So these are the fumaric esters, to include Tecfidera, dimethylfumarate, and Fumarate, diroximel fumarate. And these are pills, and they're processed through your gut, and you can have GI upset and diarrhea. They're metabolized by your liver, and so you want to check liver enzymes. Interestingly, they can cause a facial flushing because of a prostaglandin release. And so you may take the medicine and your face gets beet red for like 15-20 minutes. It's not described as being painful, but it can be unpleasant or unsightly. Now, rarely, about less than 20% of the time, these medicines will drop your white blood cell count. They're not supposed to, but it's something that we need to check for by checking a CBC. There have been rare cases of PML with these drugs, only in the setting of when they took the drug and the lymphocyte went down. And so we like to check that. If you're on Tecfidera or Fumarate and your lymphocyte has not gone down, then we don't feel like you're at risk for PML. Lastly, when you have to take a medicine twice a day, you're more likely to miss. And it's much harder to put up with a twice-a-day medicine as compared to a once-a-day medicine. Now let's discuss Gilenya, Mayzent, Ponvory, and Zeposia, the S1P1 receptor modulators. Just an interesting little bit about history and how these drugs were named. When they discovered the molecule, the sphingosine molecule, it confused them because they found the sphingosine molecule on all these different cells: eye, lung, skin, white blood cells, and it was a mystery. It was like the mystery of the Sphinx, and so they called it sphingosine. And so my question to you guys is, do you know the riddle of the Sphinx? What walks on 4 legs in the morning, 2 legs in the afternoon, and 3 legs in the evening? Leave the answer in the comments section below. These are pills used to treat MS, and they are what I call dirty drugs. They're ubiquitous, and there are receptors they bind to in the eye, the lung, the skin, the white blood cell, and because of this, you can see a whole host of side effects. So starting off, when you first take the medicine, there is a cardiac phenomenon. As the drug binds to the myocytes of the heart, it can cause a bradycardia. This needs to be avoided by some careful maneuvers. With Gilenya, we do a first dose monitoring, where the patient must be observed for 6 hours on cardiac monitoring. And with the newer drugs, they actually have a titration schedule. If you're off any of these drugs for any length of time and you restart them, you'll have to go through that process again to make sure that the heart is okay. These drugs are metabolized by the liver, and they can cause liver enzyme elevations, and so that has to be followed. They also bind to the eye, and they can cause a rare side effect called macular edema, and so we have to monitor the eye with special eye tests that are done before you start the medicine and thereafter. If you have a history of asthma or COPD, this can be a problem with these medicines, and so you need to check some pulmonary function tests before you start. When you're on the medicine, As you recall from my earlier videos, it works as a functional immunosuppressant. And so you can see an increased risk of opportunistic infection, or you can see a slight increased risk of cancer. If you stop these drugs, there's a risk of a rebound phenomenon. And so coming off of these drugs takes a careful hand, and you don't want to stop the drug cold turkey and then not start something new, because you can literally have a massive rebound of MS disease activity, which can hospitalize you. Also, during the COVID pandemic, we've learned that if you take these medicines, they blunt vaccine effects to COVID-19. Next, we will discuss Mavenclad, or cladribine tablets, an oral medication which I refer to as microinduction. It's a form of immunosuppression, and keeping that in mind helps you understand the side effect profile. It does slightly increase the risk of cancers, although there's no pattern to the cancers, and the FDA recommends age-appropriate cancer screening. So when you're of the age of the mammogram, you get the mammogram. When you're of the age of the colonoscopy, whoop, you get the colonoscopy. And we should all be doing that, but with Mavenclad, it helps remind us because of the cancer risk. We don't recommend that people become pregnant or breastfeed on the medicine, as there's a risk potentially of teratogenicity. And it can slightly increase the risk of infection, although the window when the cells are suppressed is very short, only a couple months, and you don't have a complete knocking down of the cells. They only kind of bring them down halfway. So those kind of help inform the side effect profile of the medicine. I also think it's relevant that this medicine is discontinuous. You take 5 days the first month, 5 days the second month, and nothing for the next year, and that's weird. And the reason I bring that up is for some patients, they really don't handle that very well. It doesn't sit well with them, and they're very, very uncomfortable with the idea of induction therapy or discontinuous therapy. And I think that has to factor into the discussion as well. As it relates to COVID-19, very interestingly, this drug does not interfere with mounting a COVID vaccine response, fortunately, and it doesn't really appear to affect risk of more severe COVID. Good information to have. Next up is Tysabri, or natalizumab, an infused monoclonal given either every 4 or every 6 weeks. Now, this medicine has a risk of a rare but very serious infection called PML, or progressive multifocal leukoencephalopathy. And not every person who takes Tysabri has the same risk profile. First of all, only about half of adult humans have been exposed to the JC virus. And so if you have never been exposed to this JC virus, it can't transform into PML. And so we can check and see if you've been exposed or not. If you have been exposed and you take Tysabri, there's a very small risk of PML. And I'm talking between 100th and 1,000th of a percent. The longer you stay on Tysabri, and if you have previously had exposure to chemo, it increases that risk. And there's actually some tables that are created so your neurologist can help give you a statistical risk profile. If you are JC virus antibody negative, then you can't get PML. That's like saying if you've never been exposed to HIV, you can't get AIDS. There's another risk that we have to consider with Tysabri, and that's rebound if it's stopped cold turkey. Similar to Gilenya and the S1P1 receptors, if you stop Tysabri cold turkey and don't do anything thereafter, there's a risk of a nasty rebound, something to consider as we transition from one drug to another. I will also add that very, very rarely people can develop what's called neutralizing antibodies, where your immune system turns Tysabri biologically off. And if that happens, then you can see breakthrough disease activity. Next up, let's discuss the B-cell depleters, or the anti-CD20 molecules. So these are monoclonal antibodies to include ocrelizumab, which is Ocrevus, which is infused IV, ufatumumab, which is Kesimpta, which is a shot, and off-label rituximab, which is IV. Now, the IV medications can be associated with an infusion reaction, and that reaction is caused by what's called a cytokine release phenomenon, which is kind of like the opposite of an allergy, meaning that your highest risk of having a reaction is with the first infusion, and then that risk actually goes down over time. So it's kind of like the opposite of what you would expect with an allergy. And these infusion reactions are pre-treated with medicine. So we give patients medicines before we give them the B-cell depleters to prepare their bodies to handle it better. The B-cell depleters deplete B cells, and so they suppress a sliver of your immune response. And as a result, you can see an increased risk of infection. We want to check and make sure that you don't have opportunistic infections like tuberculosis. We want to make sure that you mount responses to varicella, etc., before you start the medication. We've learned during the COVID pandemic that if you've been on these medicines for a while and then you receive a COVID vaccine, it doesn't work as well. If you're vaccinated and then start the medicines, on the other hand, that actually works just fine. Also, if you're on these medicines and you contract COVID, it may be a more severe infection. There are some patients that describe a phenomenon which they call the crap gap, which leading up to the month before your ocrelizumab or even in the last week of your Kesimpta, you may have a seeming wearing off effect where MS symptoms may return. Fortunately, this isn't very common, and in patients where it happens, there are things, lotions and potions that we can use to help get them through that time period. Lastly, I'll share that these medicines are not metabolized by your liver or kidneys. They're catabolized, they dissolve in the bloodstream, and as a result, we don't have to check liver enzymes or kidney function tests. Lemtrada, or alemtuzumab, has 4 side effects that I want to keep in mind. The first is infusion reactions, which are much more common than with other medicines that I've talked about today. 93% of people have infusion reactions. Just like with the B-cell depleters, we can give pre-medications to prepare the body to tolerate it well. And there have actually been a couple strokes because of high blood pressure during the infusion period. Infusion reactions, fortunately, only last for about 24 hours after the infusion, and we can mitigate those risks. The second thing that we want to keep in mind is that this medicine can cause autoimmunity. It's being used to treat an autoimmune condition, MS, but there's about a 41% chance of autoimmune thyroid and a very, very low chance of autoimmune kidney and even lower chance of autoimmune immune thrombocytopenia, ITP, where your platelets don't clot. And these things have to be monitored with an extensive REMS program. The third category to consider is infection. And this is an immunosuppressant, which knocks down your B and T cells, and they take months and months to come back. And during that time, you are in fact at increased risk of infection. Now, fortunately, because we can follow a white blood cell count, we can very easily tell you when the cells come back in line, and we know the numbers when it's probably going to be okay to receive a vaccine, and the numbers when it's probably going to be okay to expose yourself, and you'll be able to fight off infections. Lastly, there's a slight increased risk of cancer with this medication. Alemtuzumab, when we think about the medicines, is probably the most burdensome, most complex, and carries the most upfront risk and complexity. If you've been following this video series, we've now systematically discussed the frequency that drugs are given, the routes of administration, the mechanisms of action, the efficacy of these medicines. This video really focused on risk, tolerability, and safety. And with all this information together, we're now able to start to think about applying drugs to people. In the next video, which will probably be the last one in this series, I'm going to be talking about style of treatment. Not style like, are you a snappy dresser, but the way that we order the MS medicines based on everything that I've talked about so far. So I hope you look forward to joining me in that video very soon. And until then, or until my next Monday morning video, or my next monthly live stream, or even better yet, the next time I see you at the Boster Center for MS, this is Aaron Boster saying be safe and take care.